let's get into the trials a little bit. Maybe start with APEX.
Yeah, I think we've heard a lot in the opening discussion. I have to put a little finer point, though, on the problem with the injectables is the injection. A lot of patients don't want to be injected. I mean, about 15 to 20% of patients will say, please don't come at me with that needle again. So,
And there's probably another 15, 20% that don't say it, but then don't do it.
Don't do it. And so you have, that's in the inpatient setting. Imagine in the outpatient setting. I had a family member who got injected not subcutaneously, but intramuscularly with enoxaparin and had a rectal sheath hematoma and a basketball-sized hematoma. So
I've seen that too. I mean,
yeah.
I don't think it's as uncommon as one might otherwise imagine. It happens.
Yeah, so I've seen the safety side. I had two parents, both with pulmonary emboli. I've seen both sides of this.
And just a rectal sheath hematoma, those are extremely painful, by the way, if anyone in the audience hasn't seen them.
So we need better solutions. And you know, in the APEX study, we really wanted to see, could we strike the right balance? Could we reduce these events without causing bleeding? That's really the issue. And we randomized patients to either the standard treatment, enoxaparin, in the hospital, or to an oral drug called betrixaban, which has a longer half-life, a factor Xa inhibitor, for an extended duration, out to 35 to 42 days. Double blind, and you got both active drug and a placebo, matching placebo, so no one knew what was going on. The primary endpoint was both symptomatic VTE, as defined earlier, as well as a positive ultrasound. And we saw an event reduction from 8.5% down to 6.9%. Now that's you know, as in terms of absolute risk reduction and number needed to treat, very good. And that came with no penalty in terms of major bleeding. I think it was 0.6 and 0.7% rates of major bleeds. I think some of this is because, you know, the drug did have a half-life that didn't give big peaks and valleys, a longer half-life, and also it's not cleared. You know, the renal clearance is such that you could give it across a range of patients with different renal clearances. So we overcame some of the problems that have been seen before with too much bleeding. We could prevent some events with extended duration prophylaxis, but the penalty was too high. I think it gave us hope that we might be able to accomplish this without excess bleeding.
Yeah, no, a really great trial and great results. Great acronym as well. I like it, APEX. Maybe we can talk a bit about Mariner and Magellan. Any takers for those trials?
Sure. I'll start maybe with Mariner, and then maybe Alex wants to build on that with the Magellan, because it's a progression. So the Mariner study really sought to address a simple question, which is in people, high-risk medical patients admitted to hospital, like we've talked about, they get prophylaxis in hospital, they don't have venous thromboembolism, they're ready to be discharged. Should I now prescribe extended prophylaxis for up to 45 days? And so the patients were randomized to 10 milligrams of rivaroxaban or 7.5 milligrams of rivaroxaban in a stratified way, or placebo. And the study focused on symptomatic events and VT-related death out to that time. And the study was large, 12,000 patients, was not able to show a statistical reduction in fatal events, but did show a reduction in symptomatic venous thromboembolic events independently adjudicated by an independent committee. And similar to APEX, and Mike's point is very important, the risk of major bleeding was very low at about 0.3, 0.4%. So, you know, we have two studies now, and I think this is a crucial thing. We have two studies now with oral anticoagulant options that we can give safely for prevention. And that means we should get away from any lingering psychology about anticoagulant bleeding in these prevention, which is really driven from our history with warfarin and how people have thought about that. And the final thing is, just to build on Mike's, what was impressive is that if you look at these studies, now we talk about these rates of events and major bleeding. It's pretty clear that that the number of deaths due to pulmonary embolism in these big studies, APEX 7,500, Mariner 12,000, the number of deaths due to pulmonary embolism is about 20 times the number of deaths that we cause by a bleed. So,
That's a really
so
important
VTE
ratio.
causes much more death and morbidity over 4 to 6 weeks after hospital than we cause harm by trying to prevent it. And that's really, really important because doctors first do no harm, and they're really worried about causing bleeding in these patients. But our regimens now are much, much, much improved if you select the patient properly.
Sort of like AFib, right, where
Yep.
physicians under anticoagulate, not because they don't know the data or that they don't want to help their patients, it's just that fear of bleeding. And as you know, it often is exacerbated in that higher risk older patient who's at the highest risk for thromboembolic complications from AFib, where they don't get anticoagulated. So sort of the same thing here, where it's that fear of bleeding.
And we saw no excess risk of fatal bleeds with Matrixaban. And then we looked at net clinical benefit being, what was the risk of fatal or irreversible harm events? And on the fatal irreversible side, on the ischemic side, we looked at pulmonary embolism. We actually added in stroke and heart attack. And on the bleeding side, we had ICH and fatal bleeds. And there, the treatment really was much, much more in favor on the net benefit side. So when you lump in all the things we worry most about, there's a tremendous advantage for treatment.